another 10-minute scenario. Let us assume you got a patient with a 60 cc prostate. Again, failed medical management, quite young, 55-year-old, wishes to preserve the sexual activity, and IPS score is like 30 out of 35, quite tormented with the side effects of finasteride like lack of libido and also the absence of ejaculation due to tamsulosin. So, what are all the options he has?
Take into account his age and his prostate size. I will be talking to him about sexually preservative endoscopic approach to treat his bladder outflow obstruction and improve his symptoms. This can be either in the ablative method, such as Rezume and Aquablation, or non-ablative method, such as the prostatic UroLift and iTind, as well as the prostate artery embolization, which is considered as ablative method. And we'll also be talking to him about TORP, but I will highlight the sexual side effects associated with.
Okay, take me through Rezume, how it works.
Rezume, it's a convective water vapor technology by which there is frequently energy generate thermal energy upon contact with tissue. It does form or cause cell necrosis in a steam or liquid phase. It comes as a cystoscopic integrated method by which various injections deployed into the prostatic adenoma tissue takes about 10 to 15 minutes, can be done under regional anesthetic, local anesthetic, or sedation, or even general anesthetic. It does proven to have a good improvement in the IPSS parameters, quality of life, less sexual side effects rate compared to other methods such as TRP. The evidence of Resume comes from the McBain study, which is a voluntary study, and that has compared Resume to sham, and it was found improvement in the IPSS parameters and a less sexual side effects profile and good quality of life outcome. The limitation of Resume, it cannot be used in conjunction with penile implant or urethral sphincter devices. This is the limitation. And it does have a reoperation rate of around 4 to 5% in the duration of that McBain study data.
Okay, so take me through the aquablation, which you mentioned.
Aquablation is image-guided robotic ablation. Comes as a thrust probe and a cystoscopic integrated device, and then the ablation deployed using the device. It will, like a hydrodissection energy, used to ablate the tissue, but it will spare the capsules and the blood vessels. And therefore, some of the limitation of that technology, it will need accessory procedure to achieve hemostasis. There will be additional cystoscopy and cystothermy to achieve hemostasis. It can be done under general anesthetic or local anesthetic or sedation. The evidence of aquablation comes from the water jet study 1 and 2, with the water study 1 and 2, and they have compared aquablation to TRP. In the water 2, they have included a bigger process size of greater than 80 cc, and it was 2 years follow-up. And it was found the technology has shown significant improvement in the IPSS parameters, quality of life, less morbidity, and again, less sexual side effects. Currently, NICE has approved the technology, but only to be used under governance and in an audited units. So it's not available in every unit.
Okay. So tell me about prostatic artery embolization.
Prostatic artery embolization, works by injection of polyvinyl alcohol through either radial or femoral axis. Can be done under local anesthetic or sedation. Most cases done as a day case, more than 70%. It does have less morbidity and good recovery and improvement in the RPSS parameters. It does have, however, higher reoperation rate, it's around 20%, and the RPSS improvement is found to be inferior to TURP, and the evidence of that comes from the UK Europe study, which included around 300 patients, and it was concluded that the improvement noted, but as a cost of reoperation rate of around 20%.
Okay. Take me through the prostatic urethral lift.
This is an integrated cystoscopic device by using a deployment of implant between 4 to 6 implant to enroach the lateral lobes and obtain a patent or open prostatic urethra. It does use permanent metals. On the capsular side, the metals are made of nitinol, and the urethral side, they are made of stainless steel. And in between, there is a permanent suture made of PET. The evidence of the UroLift has shown from the LIFT study originally, which is around 300 patients, and it was found there is an improvement in the RPSS parameters and quality of life and less sexual side effects compared to the sham in the study. And later on, the mid-lift group has published the cohort, which around 45 patients, and it was found that prostate with middle lobe can be treated with comparable results to the lift cohort. But the limitations there was only small group of patients, around 45. And it does have a reoperation rate around 10 to 12%.
Is there any role of prostatic urethral lift in retention patients?
Yes, that has shown in the PULSAR study, Mark Rochester's group. It was around 50 patients included in that study, and it was found that UroLift is useful by improvement in the RPSS parameters and quality of life. More than 60 to 70 patients in that group has been catheter-free by 6 months, and they reported good quality of life and less sexual side effects at the end of the study.
What are the complications of prostatic urethral lift?
There is a general complication, which include infections and bleeding, less anesthetic complication as it can be done under local anesthetic. There is a risk of further retention, require catheterization or further treatment, failure of the procedure to improve symptoms, risk of recurrent UTI, risk of migration of the implants, and worsening storage tract symptoms, bladder stone formation as a result of the implant, but there is less sexual side effects, less retrograde ejaculation and impotence compared to TRP.
Okay. Do you aware of any prostatic injections available? Intraprostatic injections?
Intraprostatic injection? No, I'm afraid, no.
Okay. What do you know about iTind?
iTind is a device which has three elongated strut with anchoring leaflet deployed in the prostate around the bladder neck, and it perform or cause ischemic necrosis. It's left there for around 5 days. And the incision, it will create an incision like Mercedes-Benz sign incision, and it will need cystoscopy later on to remove the device. It can be done under regional anesthetic sedation or local anesthetic. It does have good perioperative outcome, less perioperative morbidity, and show good recovery in terms of less sexual side effects and good IPSS parameters improvement. The results is still ongoing. This is under the Kotel et al. Group, which compared the iTind to TRP, but it's still pending results to be informed about how, in terms of like long-term outcome.
Okay, any prostatic stents you are aware of?
Prostatic stents, this can, there is a metallic stents has been used previously, like a Memocath stent, which I'm not too familiar with this use, as it's currently become less popular due to availability of other minimally invasive techniques. It deployed through under guidance, cystoscopy guidance under vision, does have associated risks of bleeding and infection, incrustation, migration, worsening lower tract symptoms, urethral stricture, and urethral and bladder injury.
Okay, very good. Well done. The time is up now. It's almost 11 minutes now. Do you have anything to ask before I give feedback?
No, just these minimally invasive techniques, they are very good, but I think it just need like more brushing up.
Yeah, but you have done very well. As usual, I will easily say on a good day your marks will be 8, unless if that particular examiner is so well versed in the techniques and he's just looking into small things. But as you know, in our group, our primary aim is to make sure that everybody should pass. That's our primary aim. But once I'm confident that a candidate is definitely going to pass, my aim is to push a little bit more so that they will head towards like a good pass, or maybe even why not a gold medal, which obviously we are not overwhelmingly aiming for. But if it happens by itself, let it happen. Let's don't stop it. And you are really above the level of passing and all, so don't worry at all. But I will certainly give you a feedback so that you can brush this further to a much more better level. Always it's nice to do like absolutely sky shattering performance in 2-3 tables, and then like good pass performance in rest of the tables. In that case, if you have one bad table, it doesn't matter, the results will be always good. This is how it should look. Once you finish and come out of the 8 tables, you should feel 2-3 tables I literally shattered the examiner, 5 tables definite pass, 1 table I should have done better, or it's bit uncomfortable feeling. If that is the case, then definitely there is a pass. The uncomfortable feeling should not be more than 1 table. That is only one thing you need to remember. You know how the average mark works, everybody. Okay? Now, regarding Rezume, you can bring in a little bit more meat to the answer. Like for example, it uses convective therapy, not using the previous methods of transurethral needle ablation or transurethral microwave therapy like conduction therapy. The problem with conduction is it happens by necrosis and everything is burnt out. While convection therapy, it works by spread of energy from one layer to other layer, and the capsule is maintained, all the stroma is maintained, so only the actual obstructing prostatic tissue is getting necrosed or later getting apoptosed. and causes significant side effects like storage LUTS for initial few days. That's why patients should have 100% catheter at least for 3 days. And yeah, it uses normal saline. Every injection is like 9 seconds timed injection. After 9 seconds the needle automatically pulls out. You need to stay 1 centimeter away from the bladder neck. If there is a median lobe, it can be treated by 1 or 2 injections. And now there are a lot of studies, especially from people from Canada, stating that we don't need too much injections. Minimal injections like even 2 on the left, 2 on the right works good. There are some studies to say we don't have to give so many injections like how we thought before. Coming to aquablation, you mentioned just on the passing that it can be done under sedation and local anesthesia. No. Aquablation definitely needs GA or spinal. There is no way you can do under sedation or local anesthesia because it has got a rigid equipment and it's not operated by hand, it's operated by a fixed robotic hand. If patient moves around, it can cause quite drastic injury to prostate and urethra. So spinal or GA is a must for aquablation. And even though we have water 2 study on higher size prostates, as of now it is still restricted to 80 cc prostate for practical purposes, and as you said correctly, it has to be done under clinical governance. In the UroLift, you said the normal clips are like 4 to 6, but the better numbers are 2 to 6 because you can do lots of UroLifts with just 2 clips, 1 on the left, 1 on the right, especially if the prostate is less than 40 cc. So the normal clip used is 2, if not 4. 6 is actually quite rare. And other than that, things are quite good. I'm quite happy with that. In UroLift, you can say there is no sexual side effects because we are staying above 3 o'clock and 9 o'clock. The vessels for erection are traveling below that level, so there is no sexual side effect, whether it's ejaculatory effect or erection, both are completely maintained as it is. If the patient had previously some erectile problems, it will improve only minimally because we are just de-obstructing the prostate, but there won't be any de novo new onset of erectile problems. And other than that, intraprostatic injections, again, it's not a very common practice. At least if the examiner asks, you should be able to say like there are some evidences or publications on use of botulinum toxin A or fexaprodite trifolate, and there are some numbers like PRX302. They're all like intraprostatic injections, but you can say that it's not proven well and it's not in the practice. In fact, EAU 2022 clearly says do not offer intraprostatic injections like botulinum toxin for male LUTS. But if the examiner asks, you should say that yes, it is available, but it's not in practice, not approved by guidelines. And iTind works just like Turner Warwick incision. So there is an incision at 12 o'clock, 7 o'clock, and say 5 o'clock. So both sides of 6 o'clock in the lower part, and there is a small tongue-like projection to control the median lobe also. It is more for prostates less than 40 cc, which you haven't mentioned. So for very small prostates, just like transurethral incision of prostate. And the advantages can be placed and removed under sedation, and an experienced person, they may be even able to do under local anesthesia. Regarding the stents, apart from Memocath, you can mention about Allium stents and Rezume stents. Allium is a triangular nitinol self-expanding stents covered with a polymer sheath, and because of the sheath there won't be any ingrowing of the prostate. And there is a 12-month series which showed improvement in the IPSS score and Qmax. Allium is available for everything. You can use different length for ureter. There are Allium stents available even for the complete urethral stricture. So Allium stents you can remember. And Rezume stent is another newer one from Rocamed, where it can be placed and removed, and not really removed. It's more of like continuous draining bladder catheter. So it can be placed under local anesthesia. Previously there was a restriction to change every month, but now you can change even every 3rd month. That makes the procedure a little bit long standing. So when you discuss stent, bring Allium and Rezume stents also.
Rezume stent,
okay. I mean, we are going to do it very, very extensively. This kind of knowledge will make sure that the chances of failure is absolutely non-existent. That is my aim. So
Yeah,
yeah,
agree.
don't get gobsmacked by the depth of the knowledge. But if you plan for this depth, even if you fall shorter, the pass is definitely assured. Okay,
Still, yeah, no, I agree. Thank you, thank you. Very
good.
good, very good.
Anything you want to add before I open it for the other candidates to ask any questions?
No. Very good discussion. Yeah, very good feedback. As you said, like I think the BBH study, one of these tables, like
Yeah.
have to be all of the extent of the scenarios and the studies and the numbers. So it's a very big topic to explore. So it's good that we covered it.
Quite a rapidly changing topic also, and needs to update. Whatever I'm teaching now may slightly change before November or this January, so we need to keep things updated. Any inputs from anybody in the floor? Okay, if there is no further things to add, we will complete the session for today. I will select which table for next week.
Mr. Dhanashekhar, I'm sorry, I'm just interrupting. One question. Is there any limitation to what process size you can use this for? Is it 60 cc or less than 80 cc?
For which energy source?
You like all of these, because I'm trying to remember all of
numbers. Yeah.
QRP, HOLEP. So my impression is more than 80, you can go down the HOLEP route. For less than 80, can you offer all of these, or do they have to be 60?
Yeah.
Less than 60 cc?
The easiest method to remember is remember 40 80. Just only 2 volumes. Don't make it very complex. Any prostate less than 40 cc, the choices are things like Rezume, allium stent, iTind, and transurethral incision of prostate. These 4 are prostates less than 40 cc. In fact, transurethral incision of prostate is, for correctly speaking, 30 cc, but you can't remember everything. So easy to say these 4 are less than 40 cc. And then any prostate more than 80 cc is enucleation or simple prostatectomy. Enucleation may be holmium, green light, thulium, anything, or even open enucleation. And simple prostatectomy again may be like open prostatectomy like Millins or Frey's, as we discussed, or robotic assisted. Anything more than 80 cc. All other thing less than 80 cc. UroLift, Rezume, Aquablation, everything. All other thing less than 80 cc. Aquablation is done in water too steady. They have taken it more than 80 cc. But practical purposes, all other thing less than 80 cc. Okay?
Okay.
Yeah. That's good. I will decide which is the good topic for the next week table, and we'll take it forward. Well done, Sami. I will keep posted in the group so that if somebody wants to present also, please feel free to share your details and we will discuss.
Yeah, no, thank you, Mr. D. Yeah, looking forward to it. Thank you.
Have a nice long bank holiday weekend. Surprise gift for everyone.
Thank you. I'm on call tomorrow, but only Saturday, so still a couple of days to recover.
I'm on call for all days. Bye for now.
Okay, bye-bye.
Thank you. Bye-bye.
Bye.